This conference will now be recorded.
Good evening, and welcome to AnCan's virtual chat support group for low and intermediate risk prostate cancer for Monday, March the 9th, 2026. A special welcome to our first-time visitors, as well as hello to our regular participants. I am Boykin Jordan, your moderator for this evening. I will be assisted by Bill Franklin, Stuart Jordan, no relationship, David Sharp, and AnCan's founder, Rick Davis. AnCan would like to note that this group is a peer-to-peer group support group and should not be construed as medical advice. We're here to share our collective experience and answer your questions. We hope to provide valuable information that we encourage you to discuss with your doctors. Before we begin, AnCan would like to thank our sponsors for all of our prostate cancer virtual support groups. They are Novartis, Telex, Blue Earth Diagnostics, and Foundation Medicine. As well as thanking our participant base, if you would like to support AnCan, please visit us at our website, www.ancan.org. At AnCan, we have multiple prostate cancer support groups for our attendees. We have a group that focuses on active surveillance for those who are considering or have opted to postpone or avoid inactive treatment. Tonight's group, which addresses those with low or intermediate risk that are planning for or have had an active treatment. We do not address recurrence in this group and instead invite those people to join our high-risk, recurrent, and advanced prostate cancer group. We also have special groups for veterans and men under 60, as well as we have a gay and bilateral and a European group as well. Okay, with that, Steve, we will start off with you. Welcome, Steve, and just to get started, can you give us your first name and your last name?
Sure. This is Steve Koch, spelled K-O-C-H.
Okay. How old are you, Steve?
I'm 68.
Okay. Where do you live? Like state, major metropolitan area, something like that?
I'm in northern New Mexico in the town of Los Alamos.
Okay. Okay. Since you're coming from active surveillance, what was your PSA at diagnosis, or your most recent PSA?
My most recent PSA, I'm going to say 7.4.
Okay. Have you had an MRI?
I have had 2 now.
Okay. I ask some questions about that. Did the MRI? I'll come back to MRI questions. So you guys help me with that. Have you had a biopsy?
Yes, I just had my second biopsy.
Okay. And how many cores on your second biopsy were positive?
Give me a second here. I'll count that up. Are we talking 3 + 3 is positive?
Yes.
Okay. Let's see. 1, 2, 3, 4, 5 out of 12.
5 out of 12. Okay. Thank you. And then what was your Gleason score?
4. It's now 4 + 3.
4 + 3. Okay. For the 4 + 3, did they tell you what percentage is 4?
Yes. In the main lesion, it was 80%.
Okay.
And in another location, 70%. And
Okay.
then those were the two cores that were 4+3. Two cores that were 3+4 were each 10% 4.
Okay. So you had 2 cores that was 4+3,
Yes.
and 3 cores that was 3+4.
2 cores that were 3+4, and then 1 core that was 3+3.
Okay. Got you. Thank you.
Mm-hmm.
Hit that completely fine. Okay. For your biopsy, was it a fusion biopsy?
It was.
Okay. And was it transperineal as well?
Yes.
Okay. Thank you. Have you gotten a second opinion on your slides yet? Your biopsy
Yes,
slides?
I have.
Okay.
And very, very similar report.
Okay.
The percentage of the 4s were the same.
Okay. Okay. Can I ask who you did the second opinion?
Sure. The second opinion was just done at University of Colorado Anschutz Cancer Center in Aurora, Colorado.
Okay. Gotcha. Okay. Have you had a PET scan?
I have.
Okay. What type of scan was that?
PSMA.
Okay. What were the results?
Nothing extended past the prostate itself. No, there was everything was. It was an odd term. They didn't call it normal. They said not abnormal, something like that. For every other body part except the prostate. So the clinicians I spoke to and the report said that it was contained, but as far as they can tell, there's no signs of any spread outside of the prostate.
Okay. Did they say prostate or prostate bed?
I may not have printed that one out. I'm not sure.
Okay, fine. We'll just go with what you said. We'll go with prostate for now. That's okay.
Mm-hmm.
Yep. Okay. Who's on your medical team? Do you have a radiation oncologist?
So I've been jumping around. I went to at Rick's recommendation to get the fusion biopsy at Mayo in Phoenix with a Dr. Frendel. I thought that went very well. And we found out that although I didn't enjoy that long drive to Phoenix, Denver was closer, and they offered a multidisciplinary consultation with a number of specialties. And I could, the the radiation oncologist that I consulted with on Friday was I can't remember his first name. It was a Dr. Robin, Robyn.
Okay. Okay. What about a urology oncologist?
I didn't speak with one specifically, and I don't know the names of the other doctors that were
Okay.
on that board. They said there were 11 different doctors. So.
Oh, okay. But I think I wanted to only focus on the ones that you're seeing.
Okay.
And so we'll just stay with where we're at for now. And then what medical system are you in? Let me ask you that last one, and then I have another question for you.
Well, is that, you mean like insurance or?
Yes. Who's seeing you? Not necessarily who's paying, but who are you seeing? Like, is it like the university? I'm just making this up. Is it like the University of New Mexico health system, that kind of thing? Is it Kaiser Permanente?
So, I'm now, because I did a biopsy with Mayo Phoenix,
Okay.
I'm a patient of theirs, and I did the consultation with the University of Colorado Anschutz. I have sent my chart to the University of New Mexico, and they just called me back today, left a message that I could call them and set up an appointment if I wanted to work with them. But I haven't spoken with any medical professionals at UNM.
Okay, but you're kind of still working with those three, it sounds like. Okay, so I want to bounce back. I want to ask about have you had any germline testing done?
Yes.
Okay, what were the results?
Negative. I learned about this the PROMISE study, right, through AnCan, and all 29 genes they looked at were negative for any mutations.
Okay.
Including the BRCAs.
Okay. Got it. Okay. And we already have your contact information in the system since you're coming from active surveillance. And are you on the mailing list for our lower intermediate?
I'm trying to remember. I think I do get the reminder emails.
Okay.
I think I do.
Okay. We'll double check. We'll double check to make sure you're getting the lower intermediate one in particular. Okay. Stuart, I know you have your hand up. You want to ask a question?
Yeah. Hi, Steve.
Hi.
A couple of quick questions. Just to understand the history a little bit more, since this is your second biopsy, how long before that was your first one? And were all of the 3+4s and 4+3s new on this second biopsy?
The first one was conducted in August of 2024. And the result of that biopsy was I had one core 3+4 with only 5% 4.
Got it. So the other 4 all showed up on the second one?
Yes. That first biopsy was not MRI guided. Not MRI-fusion, I should say. We had the urologist had an MRI, but it did the cognitive approach.
Got it.
Okay. Are you good? Are you good, Stuart?
Yep, that's good. Thanks.
Okay. So, Steve, what question do you have for us?
So the other piece of information with regard to my prostate is given that it's grown to over 100 cc's. I've been having diagnosed with BPH, and on that difficulty questionnaire with regard to BPH symptoms, I'm generally score around a 20, which is at the high end of that, meaning I'm on essentially Flomax to manage those symptoms, but if I were to treat this with radiation, I would two different radiation oncologists said I would have to have that BPH treated, with either a HOLUP or aquablation or TURP, and that would cause great difficulty. It would make radiation much more difficult. And so what I'm looking to get is a second opinion on treating the cancer with radiation. And then I'm also looking to get recommendations, if I can go anywhere, on who the best surgeon would be if I went with a RP.
Okay, I think we got it. Okay. David, go ahead. I see your hand up.
I don't know, Steve, if you've considered whether you'll be going on hormone therapy, but what I did and what several doctors have told me is that if by going on hormone therapy, you can shrink the size of your prostate anywhere from 30 to 50%. And depending on the kind of treatment you do, that would definitely get it down to a manageable level for radiation purposes. I don't know anything about surgery really one way or the other, but that would be maybe solve two problems at once. It would shrink your prostate and it would put the cancer in a state of hibernation so that you don't have to worry about it spreading for a while. And that'll give you time to think through your options and maybe talk to more doctors without being concerned that the cancer is doing things you don't want it to do. And in the doctors I spoke with, a couple of them said 2 months is sufficient. Others said 3. I personally did 3, just to be on the safe side. And also, I wanted that extra time to, explore my treatment options. So, aside rather than doing a hole up or some other kind of TURP procedure, that's just one option to consider.
Thank you. The radiation oncologist that you see in the consultation did say that if I went with him, that I would need to be on ADT for 6 months. It would start that 3 months before the radiation treatment, and that and he was assuming that then I would have had a surgical procedure to clean out the prostate, that would indicate I would have to do 8 weeks of a low dose of radiation. So I was not very excited to hear that, to have to go on 6 months of ADT and 8 weeks of radiation, especially as a center that's in a whole nother state. So, but thank you for bringing up the hormone treatment.
And regarding the hormone treatment, before I went on it, I was extremely apprehensive about it. I, overly dramatically said to my wife, okay, I had the first pill. I was like, okay, my life changes today. No, it didn't. not really at all. The side effects were, I went with Orgovyx. The side effects were mild, limited to a nightly hot flash and loss of sex drive during that period of time. It kicked in about a week and a half and wore off completely after about 2 months. It did a fantastic job. As long as you're exercising rigorously, particularly weight training while on it, 6 months is a relatively short time for any significant side effects from Orgovyx to occur.
Okay.
In general.
Orgovix.
Orgovyx, I believe.
VYX. Okay, thank you. Okay, I didn't get the name of the specific medication, just that it would be an injection once a month, I think.
Okay, that would be something like Lupron.
Yeah.
I specifically avoided that because it takes a lot longer to take effect. So it doesn't benefit you for a good while. But then once you stop, it takes a very long time compared to Orgovyx to wear off.
Okay. Thank you.
Right. Yeah. And you can coordinate your radiation, your hormone therapy shots with other visits. So you should be able to manage that if you're doing it right. One of the recommendations that we have is that for surgeons and radiation oncologists, you ought to look at University of California, San Francisco, UCSF, and UCLA. And there's others that can talk a whole lot more intelligent if you need more specifics than that. But they have good docs out there.
Thank you.
So let's give you some specific names. And the other thing is the the Orgovyx is exactly the same, does exactly the same as what your doctors recommended. It's just a much more efficient and better drug. And if you can get it and your insurance will cover it, you're better off. How old are you, Steve?
68, and I have Medicare, so I assume
So you're on
Medicare will cover
Medicare.
it.
So depending on your Medicare, it should cover most of the plans are covering Orgovyx at this point in time, so it shouldn't be too hard. The reason why we say UCSF or UCLA is because both those places have really good radiation oncologists and surgeons. So you can go and visit both places and you can get a twofer and see the surgeon and see the radiation oncologist at the same time. So you'll be able to talk to both of them and make your decision. Your prostate is probably too large to consider brachytherapy, even if we shrink it down. Because even if we shrink it down, it's going to be on the margin. In terms of how much radiation you probably need, I doubt very much whether it's going to be the number of sessions that your guy told you. He just doesn't have the right equipment. So he's telling you what he'd do with his equipment, which is somewhere between 25 and 45 sessions, depending on how they assess you. In a center of excellence, you'll be able to shrink that down to probably somewhere between 2 and 5 sessions with a different type of equipment, with SBRT equipment. And whether you need a boost or not, it's going to be up to the docs. So the doctors we'd suggest at UCLA would probably be Dr. Kishan with his MRI-Linac, KISHAN, and somebody, or I'm the somebody. I'll put a link for him in the chat window momentarily. And Dr. Egner, if he has his license yet, because he's come over from the University of Chicago to head up the urology group there, and he's waiting on California to give him a California license, but he would be definitely the surgeon I would want if and if he's not available, we can give you other names.
Right.
At UCSF, I would recommend Dr. Roach, because he's going to give you the least number of SBRTs that anybody would. So he only gives 4 when most other people give 5, because he doesn't think you need it. And if you need a boost, he only gives you 2. And then the boost is usually the IMRT, so that can be 18 to 20 sessions. But you probably don't need a boost. There's nothing you said that would suggest it. But Mac's going to give you the least number of treatments. And then for a surgeon there, ideally Dr. Carroll, but he's not seeing that many people anymore. He's trying to retire and have lunch with his friends, which I know he did today. So I would try for Dr. Carroll. If you can't get Dr. Carroll, Dr. Cooperberg is really good. Dr. Washington is really good. We can give you other names. I could look, but the 2 names off the top that I'd start with would be Dr. Carroll or Dr. Cooperberg.
Great. Thank you.
Okay, thank you. Steve, does that help you out, get you going where you need to go?
Quite a bit. I got to tell you that I greatly appreciated Rick's recommendation of Dr. Frendel, because when it comes to a transperineal biopsy, that that went perfectly. So I'm looking forward to your other recommendations here. Thank you.
Okay, well, Stuart just suggested Dr. Brisbane at UCLA. If Dr. Egner isn't ready yet, yeah, Dr. Brisbane's a great suggestion as well.
Great.
And let me put some of these names in the. I'll start working on getting a few of these names into the chat for you.
So okay. So as we start to transition, I noticed Mark Mizrek, you came in. All right, let me ask a question. Are you new?
No, I've been here before.
Okay. Do you need any time tonight?
Not necessarily, no.
Okay. And I see Henry is here as well. Henry?
No, I'm all set. I'm all set. Thanks.
Okay. Okay. Great. Okay. So now we'll start the update. Oh. Okay. Thanks for muting, Henry. Okay. Bob.
Yes.
You're up, buddy. What do you want to tell us?
Okay.
Hold on a second before you move on, Boykin. Is there anybody else who would like to say anything to Steve, or are we done with Steve?
Just thought of another question.
Oh.
One more question for you. So I know I could take a look at the Sloan Kettering nomograms to get an idea of future disease progression. So the other question I have is how, and I know this is a medical question, how quickly do I need to get treatment, right? I figure I have to get it by the end of the year, but do I have 6 months, or is this?
Well, we can't give you that medical advice. We can only tell you our experience, and I'll tell you my experience, which isn't really on point for you. And then hopefully somebody else in here will tell you their experience that might be better. Because I was a stage 3, 4+4. So I was a little more along the way. And my doc told me that without taking hormones or anything else, that I was conclusively diagnosed in the August, I think it was, and he told me I had to get treatment by the end of the year. So that's like 4.5 months. So I don't know. Anybody else here given any time frames? Any of you who were 4+3s?
David.
Well, I was diagnosed officially in late January. I didn't get treated till July, but Steve, like I was saying, because I was on Orgovyx, which I began in March, that just stopped everything. So really, from January to July, it was like the clock had stopped in March. So that was one of the perks of going on that medication for me.
Thank you.
Steve, there was a study done at Johns Hopkins many years ago, back when there was a backlog on waiting for surgery. And they concluded at the time that for the guys who were waiting up to 4 months to get into surgery, that when they tracked those guys out versus the ones who.
Stuart, you froze.
You there? Sorry, my internet just cut out. They found out that guys that they waited 4 months versus getting treated faster long term, there was no difference in their situation.
Okay. Thank you.
Steve, I would tell you my case isn't quite like yours, but from a psychological perspective, I would tell you to take the time you need to gather the facts and then make a decision and move out.
Thank you. All right. Thanks, everybody.
Okay. Oops, is there anybody else had anything? Okay. Okay, Bob, now I'm coming to you.
Sir, thank you. I just want to start off by thanking everybody in the group. This is a great group. It's helped me tremendously. So my wife has been doing a great job about making me appointments at different places. At the last meeting for me 2 weeks ago was the day before I went to Mayo. I met with a Dr. Artera. Long story short, he suggested SBRT with photons and gold fiducials, and I guess he'd be using a spacer. I just got back from last week. I got back from MD Anderson, where I had a really good appointment, very thorough. They took my blood. My PSA for some reason had dropped. Last year I was running a 4 to a 4.9, and my PSA was down to a 3.1. They did a digital exam on me, said my prostate felt good. It's 29 grams. Met with a surgeon, which I wasn't real enthusiastic about. Not that there was anything wrong with him. I'm just not a proponent of surgery. And then met with a oncologist whose nurse was probably the best person I talked to. So at MD Anderson, they had a little mix up on appointments, and instead of me meeting with the team downtown at the main location, they sent me out to Sugar Land, which is a suburb. Instead of me meeting with a genitourinary oncologist, I met with a head, neck, and prostate oncologist. His name is Shalin Shah. So my questions tonight, got a bunch of questions. Is the Sugar Land facility as good as the main facility downtown? What is considered, what are considered the best places and the best doctors to see? MD Anderson's suggestion was that I do SBRT and ADT, the Orgovyx or Orgovyx. And then SBRT and ADT versus SBRT versus SBRT and HDR, protons versus photons, MRI guided versus MRI planning. Those are my questions.
Okay. Does anybody want to try to tackle any of those? Some of those questions may be a little too specific in terms of like the specific facilities for your location where you're looking at. I don't know if we have folks in this session that are in that area that to be able to vector you from point, which facility is better.
Well, I can travel, so
Okay.
Yeah. So
travel is not a problem.
So, I mean, just to address that one, and then I'd say Stuart should step in here and start take this one by the horns. But I think you already met the enemy with MDA. I mean, if I went to an appointment like that, I would not be happy. And why persist? Yeah, we know people who have gone to Sugar Land. Would I go to Sugar Land? Probably not. Would I go to the main facility? I'd go where I wanted to see the right doctors. I'm not going to the facility, I'm going to the doctors. And I think the better doctors tend to be at the main center. But I think that sort of a screw up tells me a lot. And so do I need to go to Houston for that sort of a screw up? You probably could have you probably could have found that at Emory, you know? And so I think that the first step, and this is why I really want Stuart to get involved, is that you've said you don't really want to do surgery, fair enough. I think you have to decide what type of treatment you want to do. And then we can help you find where the best place is to do that treatment. So, you know, we're not going to back into the treatment that's available at the facility you want to go to. We're going to find what you want to do, why you want to do it. Maybe you particularly want to do proton. We don't think it makes a difference whether you do proton. We don't think it makes a difference whether you do proton or photon. The numbers don't support that, although the proton proselytizers think it does, but we don't think so. So you got to come up with exactly what you want. You know, do you want to do brachy? Do you want to do the MRI, the guided the guided SBRT or regular SBRT? So we'll help you think that through, and then when you've thought that through, we'll try and figure out where's the best place for you to get it. Stuart, step in, man.
Yeah, Bob, I was going to start with the photon question, just because the guys who have, what is it, the proton, or claim that it's the greatest thing since sliced bread, and it's just, in most cases, the research shows there's no difference. And since they happen to spend a lot of money on that machine, that was Mayo, right, that was pushing that?
Actually, neither Mayo nor MD Anderson recommended the proton. They both recommended photon.
Who is pushing proton?
I just read about it and heard about it.
Okay. So
I've watched the videos on the MRI. Isn't the Meridian machine, the MRI guided therapy, isn't it proton, or is it proton and photon?
No, it's not proton.
Okay.
Proton is a totally separate technology. It is an incredibly expensive machine. It has been it's been installed either at free standalone places. There are some centers of excellence that have one. MSK in New York has a proton practice. It's totally separate. But again, while originally it was expected to be a better technology, the testing has not borne that out.
Okay.
So, unless you happen to be at a center of excellence that was really, encouraging it, I think that's something you can just sort of put aside and, again, focus on trying to find the better doctors to give you their suggestions on what they're recommending as the course of therapy, so that then you can sort of take into account these doctors, the ones you feel more comfortable with and what they're saying, and sort of come at it from that angle. I'm not a huge fan of falling in love with the technology, because I believe that the doctors have as much or more to do with your outcome than, which, again, I was treated with MR-Linac in New York, but the reason why I went there had more to do with the doctor than it had to do with the machine. And they talked about Dr. Roach in San Francisco. He doesn't use it because he doesn't think it's any better than the SBRT that he uses. So that's why I tend to look at it that way. And as you know, we're trying to help you find the better options in terms of doctors and centers of excellence to sort of help this. You are possibly a candidate for brachy. And, we've also talked about that. So, that's something to explore. And, MR-Linac or regular SBRT is probably, the right up your alley in terms of what you need.
Is the MRI-Linac, is that photons delivered at 360 degrees?
Yes.
Okay.
The machine, it's literally a combination of an SBRT machine and an MRI tube.
I see. So it's MRI guided.
Yes, it's real-time MRI guided, which is the special sauce for that technology. They're taking multiple MRI images per second, which allows them to tighten the targeting margins, which allows them to target the cancer and avoid hitting the good tissue.
And is the general feeling that that is superior to the MRI planned therapy?
The theory is yes, it is, because you can plan it perfectly, but if when you're on the table you move or you have a gas bubble or whatever, things change inside. One of the small benefits of doing MR-Linac is you don't have to have the fiducials implanted, which is one less invasive activity. By the downside, if you don't like taking MRIs, this is not maybe your great experience. Greg Burns, this is probably a good time for you to speak up since you just went through this also.
That is true. I've just gone through it, and I hate to jinx things, but the side effects have been quite minimum, and I'm very, very happy to say that. I could talk generically about it, but maybe if there's some specific questions, I'd be happy to answer them.
And what did you go through, Greg? You just had the MRI?
MRI-Linac. It's you do one session. It's about a 2-hour process where you go in and they give you an enema, and then they have you drink 2 or 3 cans of water, and then depending on the schedule, then you go in shortly thereafter into the tube, and you're really not in the tube for more than, I'm going to say 30 or 40 minutes, but actually it got down to about 27 minutes towards the end. So when I say the end, by the 5th session, the first session is I don't say a meet and greet. Here's your prostate, say hello. But it was a setup where they get you ready for the following 5 treatments. So there's no radiation on the first treatment, but you are in the MRI tube. But there's the one setup, and then I had 5, as I say, 27 to 40-minute sessions in the tube, and it's, as you would guess, it's painless. It's it's not a heavy lift. You don't have to use a catheter afterwards. If you're uncomfortable in the tube, they'll give you a lorazepam, which will calm you down. I'm not saying it's something I would like to do again, but to be honest, guys and girls out there, I spent 2.5 years running away from this, and having now just had it, it's been 4 weeks since my 5th treatment. Looking back, and I'm not saying I shouldn't have been scared and I shouldn't have postponed it. And I think what I did was the right thing to do. But when all having, hopefully, knock on wood, we're all cleared now and it's not recurring and things like that. But the process itself was much less upsetting, painful, whatever you want to say, than my mind had created it to be, as Rick will probably attest to. Yes, there we go.
Thanks,
And
Greg.
where did you have it done?
I had it done at Stanford, with a Dr. Boyansky. I had talked to Mac Roach. I've been in touch with him actually for the entire 2.5 years of my wait and watching active surveillance. But I decided to go with with Stanford and Boyansky because it's down the street from my house is one of the reasons. But also I liked the idea of the MRI, the Linac having the accuracy. And he does not, Boyansky does not use space or any kind of anal spacing. And knock on wood, so far I've had all my symptoms. I think I had diarrhea, a little bit of diarrhea one night, and I had just about a week ago, I had what do they call anal mucus, which was kind of a surprise. You get some seepage, if you will, that is not it's not the nicest smelling stuff, and but I found it before it got all over everything, and that's been the one thing that's happened so far. And other than that, I'm still having erections and I'm still having orgasms. So not to say what's not to like, guys, but I was, it wasn't the big bad monster that I thought it was going to be.
Thank you, Greg.
Great, thank you.
You guys are very welcome.
Yep. Larry, you had your hand up?
Yeah, I had three or four answers to questions that were not asked, so I put it in the chat. Check your get baselines for your hormone levels, especially testosterone. Figure out what your muscle strength is. If you exercise regularly, keep on doing it, and you want to see how much muscle mass you lose when you take ADT, and then if you can, see what your lean to fat ratio is, and because that can change. And also talk to your doctors. If they don't tell you about the side effects of ADT and radiation, make them explain that to you. Nobody gets all of them. Everybody's experience is different, but if you know what to expect, they won't surprise you.
So let me comment on that. I think it's good advice if you're going to be on long-term hormone therapy. In this group, we rarely see people on much longer than 6 months. If you're going to be doing more than 6 months hormone therapy, we really want to see you in the other group. I would say to you guys, based on long experience, that pretty much what David found, that if you're going on short-term hormone therapy, it's not bad to do any of these things. Probably a good idea to get a baseline testosterone, but I wouldn't be worrying about fat ratios and muscle wasting and any of that stuff, because it ain't gonna happen unless you've got some comorbidities going into it. It's not going to happen in 3 to 6 months. Now, if you're going to be on for 18 months or 2 years, yeah, it's good advice. But I don't think I don't think it's right for this group, is what I would say.
What about SBRT alone versus SBRT and ADT versus SBRT and HDR?
I think you've got to let the surgeon, the radiation oncologist, advise you what they think on that. Okay. David will speak to you, but if you're high risk, but I don't think you are. I think you're just high intermediate, or whatever they call it, the 4+3. You don't really need a boost. If you've got involvement in possibly outside or seminal vesicles or something like that, then the gold standard in the past, maybe not today, has been brachytherapy or SBRT plus IMRT plus ADT. So again, it really depends on how aggressive your disease is. But if you're only if you're fortunate enough to be just a 4+3 with no complications and a T2, I'm not sure that they would recommend it. But it's really, that's why we're saying go to a really good radiation oncologist and see what they say. And some radiation oncologists will use ADT and some will not, even in the same institutions, depending on what. I mean, we just had a situation with a guy in UCLA where one guy wanted to use ADT and another guy doing brachy didn't think ADT was necessary. So there's always going to be differences of opinions. David, you have a thought on this too.
Getting back to the ADT a second, if you go to the gym and lift weights, well, in my case, not only did I not experience muscle wasting, but in month 4 on ADT, I was lifting heavier weights than I was at the beginning.
Wow.
So I went into that with almost like the attitude of I'm in training, and just cranked on it during that period of time. Now, in month 5, I had the brachy and I had a foot problem, and that was 3 weeks I didn't exercise. And you know how it is when you completely stop exercising and you can start to notice your muscles are starting to waste away, right? You know what I'm talking about? During that 3-week period, it was like my muscles had shrunk, not the usual way you would expect in 3 weeks, but more like how you would expect them to in a couple of months while I was on ADT. But as long as you're working out, you would pretty much maintain status quo. You might even get a little better.
So the just to make sure I've got this right, the MRI-Linac with photons is the looks like the machine to go to. Am I correct there?
Well, I think Stuart made a good point about you get to skip the fiducials. Now, in the grand scheme of things, that's a small matter. It's about an hour procedure, but it's not a fun hour. It's sort of like three uh, cores of biopsy while you're wide awake. Okay, they give you a Valium, but it's if you can skip it, why not, right?
And are the best doctors genitourinary doctors, or could they be like a head, neck, and prostate, or?
These stupid questions.
Guys, let's wrap this one up because we got about 5 or 6 more people to do.
Okay, so
That's my last question.
yeah, I mean, of course, with respect, Bob, of course they're GU doctors because that's their specialty. I mean, and when you go to a surgeon or you go to a radiation now, you go to a surgeon, you're going to get a urologist, and that's his specialty. You go to a radiation oncologist, you may not get somebody who specializes in prostate, but the doctors we're sending you to certainly do. And you don't need a GU medical oncologist at your stage. You just don't need it. It's redundant. Thank God you don't have complications. You don't need it. So it muddies the waters. But when you do need one, yes, you've got to go to a GU medical oncologist, because if they're generalists, they don't know. So I think probably, I don't know where the MRI-Linac machines are. Stuart probably does. There's certainly a very, very good practitioner in New York City that Stuart saw, and you know, that's one name for you. But I just don't know where the MRI-Linac machines are on the East Coast. So, but come on back and we can help you with that.
Thank you. Thanks for the time. I appreciate it.
Okay, nope, thank you, Bob. Okay, Brian?
Okay, I'll be quick. Thanks for having me again. I am setting up my biopsy. And probably you know that I was doing it at the VA. They only do transrectal. And where they did my aquablation at a different hospital in Seattle, they only do transrectal. So started using my Medicare, which I've never used, and I called the UW, and they're in connection with the Fred Hutch. And so they called me today. I did say I wanted either a Dr. David Lind or a Dr. Montgomery Robert, because I heard that from you guys. But they gave me two other doctors, and it's scheduled for June. It's not scheduled yet. I wanted to check first. They gave me two doctors to do the biopsy. And so I'm going to schedule that tomorrow. So how important is it for that? I mean, I don't know if I can get a certain doctor to do the biopsy. Is it that important, or can I just get the biopsy done? And then I did ask him though, well, what about the MRI-fusion guided? I don't know about that. So I got to connect all them dots tomorrow. This lady was just setting up the biopsy, the transperineal biopsy, but at least I got that. So how important is it to who does that biopsy? That's one question. I guess that's the only question. And then one other thing was, since I did have an aquablation, I did hear Steve say that, and I've heard this before, once you have an aquablation or a TURP or something like that, it makes radiation harder in the future. So if I have to do radiation, is that going to be a problem since I had an aquablation and they took 20% of my prostate? Does anybody know about that also? So those are my two things.
Okay. Let me ask you, Brian, have you decided what active treatment you're going to pursue yet?
No.
Okay.
The only biopsy I've ever had was with the aquablation, where they found 3+4 and 10% 4. So I haven't really had a biopsy of the prostate, except for what they pulled out. So that's why I'm doing this biopsy. And my PSA is, my prostate's only 28 grams. My PSA is about 5.9, 5.7. So it's kind of, I think it's kind of, and the DRE is kind of mildly firm, more than mildly firm. He goes, it's more than mildly firm. No lumps, but mildly firm. So I'm just kind of concerned.
Okay. And are you getting your biopsy? It sounds like you're getting your biopsy done at a different facility.
Yes.
From where you plan to get the treatment done.
Well, whatever, I got to see what the biopsy says. I was planning on doing the biopsy at, these guys work with Fred Hutch too in Seattle, University of Washington and Fred Hutch.
Okay.
So get the biopsy done there, because they'll do the transperineal biopsy and then take that information and get my treatment at the VA. Because I don't pay for the VA stuff, but I pay for the Fred Hutch, or I pay for the UW stuff.
Okay. Well, so I would just tell you on the biopsy, I would just get the fusion guided, as we've been, the transperineal, as we've been talking about all along.
Mm-hmm.
And my opinion is, as long as there's a qualified medical, professional, and you can get the because they're not going to be the ones that are going to be doing your actual active treatment.
Oh, so it doesn't matter. So they can just do it, whoever, and I'm fine then.
I think that's my opinion, because it's essentially a test.
Okay.
You get the lab results.
Okay.
Right. And I was worried about it at first, because in my case, I had a radical prostatectomy, and the person doing my biopsy was also going to be doing.
Oh.
Right. But your case is not that way. I know that Mark from West Virginia has his hand up. So Mark, go ahead.
Okay, Brian, 4 years out from IMRT. I'm a veteran. I've had nothing but veteran services since I come back from Vietnam in 1978. Mm-hmm. So you do not have to pay for this, whatever's on the street. You need to ask and demand community care for the VA to pay for whatever transperineal biopsy they're going to do. And the one thing I know for sure that I went on the street to do my transperineal, and they found 4 spots more on the street for the transperineal than doing it through the VA. Not that the VA can't do it, but the whole thing is they didn't have the equipment that I wanted, not what they wanted, what I wanted. So I asked for a transperineal community care on the street. They said okie dokie, and they put me through that way, and that's the way I went. And then when that information came back, I came back to the VA, and the VA.
Mark, we've been through this a bunch of times with Brian, and he cannot get the VA in Washington, in Seattle, to do what they did for you. We told him exactly the same thing. But the guy in Seattle, they just won't do it. They won't send him. So this is why he's had to go back to paying for it himself. I mean, it should be, you're 100% right, but he can't get him to do it.
That's a shame.
VA's been great. They've been great. They did mock ablation, no problem. Community care. I do all my community care. Everything's been great, except there's just a little problem with this. It's a long story, so I don't really want
to. Let me back up. Go ahead, guys.
Does anybody else have any advice for Brian with respect to this?
The only concern I have, Brian, and you really do need to establish this, and you want a commitment from them, is that if you decide you need treatment, and if that treatment is surgical, that you have to make it clear you don't want to be tied to the urologists who are doing your transperineal biopsy.
Okay, good stuff.
Because in these centers of excellence, it can be difficult to switch doctors. So they give you a doctor to do the transperineal, and then you decide, oh, I want to go get surgery. And they say, oh, well, you've got to see the guy who did the transperineal. Well, you don't want that. So you have to make sure and put it in writing, put it in the portal.
Okay.
I'm happy to go. No problem, but if I need more treatment, I will reserve the right. I don't want to be assigned to these doctors. I want to discuss my doctors. And put it in writing in the portal.
That's good information right there. That's beautiful. Thank you. Thank you.
Okay. Not seeing any others with hands up. Let's move on to Tom.
Good evening, everybody. It's been about a month since I've been here because I had shoulder surgery. But in the last meeting was a really good one. Thank you guys for all your input. I've opted to proceed with hormone treatment and radiation, and that's starting next week, I guess. Yeah, I'm on hormones now. I took a hormone shot about 3 weeks ago, and they're going to start the hormone actual. I meet the oncologist again this week, and we're going to go over the 3 medications and their side effects. And then I guess I've got 2 months of that, and I'm going for radiation. Just looking for guidance on what to expect, really, because I know you thank you guys. You guys are just wonderful. You talked me out of the surgery, which was probably stupid of me to think that was a good idea. Thank you guys for that. So I kind of do like hearing your guys' feedback. But I assume the hormone treatment, they've told me all the side effects. And then I go in for the radiation, and then they're saying that I may be staying on hormone treatment for like another year. Now, that doesn't sound right, but I've never heard anybody say anything like that. So I don't know if it's counterintuitive to common practice, or maybe it's my certain condition, but I'm low intermediate. I'm not, my Gleason score isn't that high. I don't have a whole lot of, no symptoms technically. But just curious as to anybody's experience going through the first phase of the hormone treatment going into radiation, and then is it really that long that it could be in a whole year on hormones afterwards?
Marcus, you got your hand up.
Where are you getting treated, Tom? You didn't tell us that.
Okay, Memorial Sloan Kettering.
I'm sorry?
Okay.
At MSKCC?
I meet them here in Basking Ridge in New Jersey, and I go to the city for the radiation.
Okay, so I'm having a little trouble hearing you. I don't know if anybody else is. Yes. So I think you said Memorial Sloan Kettering, and you're seeing them where is locally? Monmouth Ridge? Where are you?
Basking Ridge.
Baskin Ridge, rather. Monmouth Hills, Baskin Ridge. I got them mixed up. Okay, so you're going to Baskin Ridge, but you're going to get you're going to get the radiation in the city, and what type of radiation are you getting?
I haven't really. She has a meeting. I have a meeting with her after my meeting this week, so that's next week. I'm probably. I would presume I would go for the MRI guided. That's what.
Well, don't assume that if you're meeting with her. I think you need to take a step back. Is what I'm hearing. You're sort of getting ready, and it's all 6 weeks, but you don't know what radiation. So the first thing is, it's like we said to Bob, you got to get your radiation sorted. If you're going to get MRI-Linac in Memorial Sloan Kettering, it's probably going to be with Dr. Nagar, and yet you're mentioning a lady who you're going to see, so she may be thinking of giving you, for argument's sake, 28. It makes no sense that somebody told you that you're going to be on hormone therapy for 12 months with a 3+4. So it doesn't add up. Again, I'm going to turn it over to my MSKCC man, because this isn't stacking up right. It's not quite smelling right, Mr. Jordan?
Yeah, Tom, have you talked to anybody in New York, or is your local doctor just saying you're going to be treated there? That just seems really weird.
I guess that's a good question I have to ask her, because my understanding was that they don't do the radiation in Basking Ridge; they only do it in the city.
I don't know about Basking Ridge. I know because they have a satellite in White Plains, where I was originally. They have the machinery in the other locations as a convenience factor for the patients, so that they don't have to go to New York. So that's really, again, it's really weird that they're saying they're going to send you to New York unless Basking Ridge is different. But I would want to know what my treatment is before I'm signing up and starting down the path, because the messaging is really confusing.
So what are the different types of radiation that you could elect?
Well, there's MRI-Linac, there's regular SBRT. Did they say how many treatments you were going to have?
Hang on, let me check. I do have that note.
Yeah, simple question: is it 5 or is it 28?
4 to 5 weeks of radiation. So it's 25. It's every day, so it's probably 25. Yeah.
Okay, so the question I would ask is why 4 5 weeks? There are legitimate reasons why they would be saying you should have the slower, longer process. But unless they have a good reason, the SBRT 5 treatment option, could be, quite preferable. And again, it's just very uncomfortable that you're getting pieces of information, and you know, again, it just doesn't make sense.
Yeah. Yeah, she did mention the fact that she's using a lower dosage and a longer exposure, right? Longer term. But I'm not. I don't. In my notes, it doesn't say why, and I should have asked that question, I guess. Yeah.
Yeah, it's
There's
a
an even
perfectly
bigger question that Stuart's saying is why are you even getting IMRT? Why aren't you getting SBRT or MRI-Linac or brachytherapy or what? I mean, unless you enjoy, you want to go to the hospital for 28 successive times, you don't need to do that today. And
So,
you know, I'm
so mine is so sorry to interrupt again, but I'm still putting all the pieces together, and I appreciate your knowledge. So what they've scripted for me is an IMRT, and you think the SBRT is a better route.
Who is your radiation oncologist?
That is Dr. Yalamanchili.
Dr. who?
Yalamanchili.
I don't know her. I mean, I would stick to the city. Stick to the city. That's where, by and large, the better doctors are. We mentioned that to you before. There are some exceptions. I mean, like Chuck Ryan, if you needed a GU med-onc, I think he's at Monmouth Hills, is really good. But by and large, stick to the city. Cancel this all out and say you don't want to do IMRT, you want to do MRI-Linac, and then they're going to have to send you to the city. Or say you want to do brachytherapy, they're going to have to send you to the city. But yeah, just like Stuart says, unless there's a good reason why you're not a candidate for an SBRT procedure, it drives me a little nuts that MSKCC doesn't explain this to you.
Yeah.
Give you the choice.
No, I wish I knew all my options. True, that's why I'll come to you guys.
Well, and I think you need to talk to the MRI, you need to talk to the radiation oncologist there and say, why aren't you giving me this choice? This is MSKCC. I'm not going to some 2-bit local hospital somewhere. Why don't you give me the patient the choice? I'm not just radiation fodder for you to fill up your schedule with.
Yeah.
I mean, I don't think this would happen if you were seeing a doctor in the city.
Yeah, I wasn't. You mentioned that when we first started chatting, and I was not able to transfer out of here. And you said it was going to be tough, and it was. It didn't happen.
Okay, well, one way for you to transfer is to say, I want MRI-Linac, because then they're going to have no choice. I'm not doing IMRT. I want MRI-Linac, and then that'll take you into the city, and Stuart's the boss from there on in.
Okay. All right. You guys are great. Thank you.
Okay, David, I saw you had your hand up.
Am I the only one surprised that they're telling him he needs any ADT at all as a 3+4? I thought 3+4s get a pass on that.
Yeah, I mean, at the most it should be 3 or 4 months, according to this new Kishan Spratt paper, and by and large they don't give it you anymore. And I don't understand why they're even talking 12 months. It's like somebody doesn't know what they're talking about here.
Plus,
it just doesn't add up. Plus,
as I mentioned earlier, there should be a time gap. If you are going to do ADT and as a 3+4, if I were you, I'd say, why are you telling me I need any ADT as a 3+4? But if I do need it, what's the time sequence? I mean, when are they saying you should start the ADT in relation to the start of the radiation? There should be a time gap so the ADT has a chance to shrink your prostate, and therefore, if you get beam, they don't have to use as wide of a beam, and less radiation is going to hit your body.
Exactly.
Yeah, I'm going to be on the hormones for a month prior to radiation. There's the injection, the Orgovyx, I think it was, and then hormones for a month, and then I go to radiation.
Right, and you don't want, and really, as you heard before, you don't really want Zoladex. You'd much prefer to get Orgovyx because it'll come in and go out. And again, they should be presenting these options to you. Whoever this
No, the Orgovyx.
radiation oncologist is,
I am
whoever this radiation oncologist is locally, she's not giving you a fair shake.
And I would
And
say,
I would get your ass out from under her right away and get yourself some decent treatment.
and a month isn't long enough, in my opinion.
No. Even with the injection for 30 days and then 30 days for the 2 injections. And then after the 30 days.
I just tell you what I would do. I'm not telling you what you should do. I would go to Orgovyx and take the pill. I would take it for 3 months, shrink the prostate, and then do the radiation.
Okay. 6 weeks is normally what they do, David. They normally give it 6 weeks, some longer, but most of the time they'll start you on hormone therapy 6 weeks before, but at least 6 weeks. But again, we can't give you that sort of medical advice. What we can tell you is you're not really getting the best, you're getting standard of care, but you're not getting the best treatment, and you're not getting the sort of treatment that you deserve when you go to MSKCC.
Yeah. So the 3 scripts that they have are Orgovyx, prednisone, and abiraterone. That's what they're going to have me on for 3 days.
So hold on a second. There's something is not adding. Either you don't understand your own diagnostics. Are you a 3+4?
Yeah.
Do you have they seen anything outside the prostate?
There's 2 lymph nodes that they are not able to biopsy that are undecided.
Okay. So that part of the information just came out right now. So now we're changing things a little bit. What I'm hearing is they don't know if your disease has extended. Have they given you a PSMA scan?
Yes. Yeah.
And did those lymph nodes show positive?
They lit up slightly. That's all they said. They're not showing positive.
So I think what you're going to do is so now I'm understanding. Now you're talking about prednisone and abiraterone.
Retract what I said earlier.
Right. This is a whole different ball game. It's a whole different ball game because you're not just a 3+4. There's a possibility you shouldn't be in this group. We should be talking about this in the other group. But what I would say is get yourself into the city, let Dr. Nagar determine whether he thinks those lymph nodes need treating. I would trust Nagar much rather than this local person, and then try and figure out what type of treatment you want. Stuart, what's your opinion on this now that we know that there could be lymph node involvement?
Absolutely. You just got to get better. You just got to get better answers and a better, fuller picture, Tom. I don't see where you're at a position to be able to make a decision to commit to going in any direction. And
okay, very good.
It's call New York and say I want to make an appointment with Dr. Nagar, and just don't take no for an answer.
Very good.
And be sure to ask Nagar, is he of the opinion that your disease has gone through the capsule and that you're a T3? They're treating you like you're a T3, possibly a T4, depending on where those are. And if you're stage 3 or stage 4, then you need a lot more information before you start. And maybe you do need a GU medical oncologist, but start with Dr. Nagar. If you need a GU medical oncologist, we'll tell you who to go to. you do not want to see a GU medical oncologist outside of the city unless it's Dr. Ryan. Whoever they tell you to see, say no thank you. And in terms of who you want to get on your team right now, you need somebody a little stronger than this lady. I mean, they haven't even explained to you what's going on.
Well, he didn't even explain to me all the options, which is bizarre. I mean, I had shoulder surgery, so I was out for like 3 weeks, and I'm just finally getting back on my feet and putting some puzzles back together in my life.
But it's not just they didn't explain to you the options. They didn't explain to you why they're giving you abiraterone and prednisone. Those are second line drugs. They're only given first line when we have an issue up front. And that's why, you know, maybe come back into the high risk recurrent advanced group, because if you're on abiraterone and prednisone, you are high risk.
Wow.
And for you to say wow to us here gives me a great concern, because it means your doctors haven't been explaining. We've got to move on. We've got a high risk group tomorrow. You can come into that group and we can help you unpack it a little bit more. But you need to get your ass out of there. They're not giving you a fair shake.
Okay. I will be reaching out to them. Thank you.
I'm sorry?
I will be reaching out to them. Thank you.
Yeah, and come into the high risk group tomorrow and, you know, have everything ready. That meeting starts at 6 o'clock Eastern in this room.
Should I try to compile some better answers before I go there, or does it matter?
I'm sorry?
Should I get more information, or should I just come over there? Because I don't have an invite for that one yet.
You don't need an invite to any group.
Oh, okay.
Just come into, you don't need a group. I'll make sure. What's your last name again?
Oberschmidt.
Right, I remember. So we'll make sure you get both invitations going forward, and we'll spend a little time with you yesterday, but we got to get you straightened out. First thing you do tomorrow morning is get an appointment with Nagar as soon as you can.
Okay. Very good. Thank you.
Okay. Moving on to Albert. Albert, yeah, I see you. Go ahead.
Yes, thank you.
Yes, what is your question?
Okay. I met with Kishan about 3 weeks ago, and he said I could do heat wave. I qualify for that. I thought about doing that with the adaptive therapy because it dials in even more than the MRI-Linac in terms of accuracy. And I spoke with David, and thank you, David, for helping me individually. And we talked about doing brachytherapy, and I have an appointment with Dr. Rossi in Colorado, but it's a video appointment coming up on the 16th, next Monday. So I'm looking into brachy as well. I'm still kind of hung up on possibly doing focal. Dr. Frendel at Mayo Phoenix thought it would work. Rick has weighed in the past saying not a good idea. Basically, he doesn't think I have a problem. David also weighed in, same thing, saying he thought it was nuts and woefully inadequate. I'm still like, well, it's the least invasive and they can go back in if they have to later. I've watched a Cooperberg video and they're talking about focal. So I'm a little confused there, but I feel like I need to move on. I've got the large cribriform. I'm borderline 4+3. My biopsy was in December. So here I am, January, February, March, 3 months out, haven't done anything yet. And I'm kind of stuck. It's sort of my personality to do that. And I know I need to not get bogged down here. I need to go ahead and get something done. So my plan is see what Rossi says. Kishan clearly thought he didn't recommend, he didn't say, oh, you need brachy because you've got the large cribriform morphology. He knows I've got it. And he knows I'm borderline 4.3. And he knows my Decipher is 0.52. So he was comfortable with, just do the MR-Linac or the heat wave with apalutamide and the adaptive therapy. And ADT, the apalutamide. And, you're good with that. So he's the only doctor I've met with other than Frindle who talked about the focal. So that's where I'm at, and I want to proceed. So I'll talk with Rossi, see what he says. But I still don't have somebody other than you guys to say, okay, Frindle says you could do focal. Kishan says MR-Linac's going to be enough. And Rossi says, no, you need brachy. I'm like, I don't know how to decide, but maybe I don't need to decide yet. I'd gather more information first.
I see David has his hand up. David, you're on mute, buddy.
I don't know if I made this point when we spoke, Albert, but there is a misconception that focal is without risk. It can involve some risk. There used to be somebody a year or so who came to this group who got focal and it didn't go so well and later had to undergo more definitive therapy. So there's that. It's not necessarily a walk in the park.
Yeah, I understand that. And he even explained, it's only 80% chance of success. And he said, even though they're doing focal for cribriform in Europe, or in the UK, I guess, that Frindle even said, we don't know how focal works with cribriform. So it's kind of you really could end up with having to do more treatment later. So I don't know if it's worth trying to.
What I'd like to know is what's the source of his 80% success rate? That seems high to me.
Oh, like that's more success than you would imagine?
Way more. Way more.
Yeah. Okay.
I mean, the average failure rate for focal is 50%. Average.
Wow. Okay.
And
this was HIFU specifically.
What's that?
It was HIFU specifically. I don't know if that.
The average with all of them is 50%. I think you can fairly well, and I haven't done the research. I'm not going to do it, but somebody can do it, or you can do it. But I think you'll find that the average for HIFU is probably around 50% across all grades. Okay. And the problem is that it's weighted towards 50% and not higher failure rate because there's a bunch of 3+3s that get treated who didn't need treatment.
Oh, yeah.
So then it means that if you're leaning towards the 4+3 area, your failure rate is even higher still. And I would say your failure rate's probably closer to 70% than it is to 20%. I'd have a little bet with you.
Okay.
$1,000 to AnCan if I'm wrong.
Okay.
And I don't know. I haven't heard what Cooperberg said, but I can almost guarantee that Cooperberg was talking about people with a different disease demographics to you, Albert.
All right. Well, the other issue for me is sort of the opposite end of the spectrum. Was Scholes says that beam can't deliver enough energy because it'll damage the rest of your healthy tissue the way that brachy can. And therefore, on one of his videos, he's like, you just aren't going to get the cure rates. And if I've got large cribriform and it's risky, then I'm not going to get the cure rates with beam that I would get with brachytherapy.
No, that's I would say that's a bunch of crap.
Oh. Good.
That's what I would say, but I'm not a doc. It's not my opinion. but there's plenty of people that are getting crib reform that aren't getting brachy.
Yeah.
And you can get more than enough treatment with SBRT. Is SBRT better than brachy or worse than brachy? I don't want to get into that. I don't even know. But I think that, warning people off treatments, particularly the way that Dr. Schultz does, and he has his own credibility, it doesn't sit well with me. We need to unpack what these are. We need to understand from somebody like an Albert Chang, is it enough? We need to understand from somebody like a Mac Roach, is it enough? And, you get these docs who have a reputation, and unfortunately, because they explain well, the patients believe them, and it's just not, I don't think it's healthy. But that's my opinion. I'm outspoken on it, and I get myself into trouble on it.
Right.
Okay.
Albert, we need to kind of move on, but here's my 2 cents. Find a doctor you trust and pick one path and quit trying to compare all these other different things. You're driving yourself crazy. You're making this harder on yourself. Focal is not going to work for you. You've heard that already lots of different times from lots of different people, okay? So get off the focal bandwagon and find a doctor that's going to talk to you about something that's more traditional to treat the whole gland, and then go from there. And I think you will be far better off. Just my opinion, because you're suffering from paralysis analysis, my friend.
Okay. Thank you, Boykin.
Yeah, and I'd agree 100% with Boykin. If you like Kishan, go with Kishan. If you like Rossi, go with Rossi. It's sort of going back. I know I said earlier on, choose the best. I said to Bob, choose the procedure you want, then find the best doctor. But somebody else has also said tonight, find the doctor you like and go with him. And I think it depends on your personality, and I would stand corrected. And I think Boykin's advice is terrific.
Well, Rick, do you think Rossi and Chang are on par?
They do different things.
Oh, I didn't realize. I thought they both did HDR.
Oh, I'm sorry, Rossi and Chang. Do I think Rossi and Chang are on par? I'm sorry, I beg your pardon now, but yeah, I think they're on. I mean, I don't know enough about Rossi, but I trust David Sharp's opinion. I think Chang is great. I've known him for years. I think Kishan's good. I don't know that you need apalutamide for the heat wave trial. I mean, go see Albert and get it done, man. I mean, you're making yourself crazy. Boykin's right. We got to move on. But you got to jump for, if you want to do the brachy, go with the brachy. But the SBRT will do the trick.
Yeah. Well, would you do the MR-Linac with the Orgovyx with Kishan, or would you wouldn't do heat wave?
I would do it. I would do MRI-Linac with or without Kishan, according to what he recommended, with HT, without HT. I would do the treatment with Chang, but I think you've got to do something. You can't. We don't have a crystal ball,
right?
And we're turning the same soil over and over, and we got to get going, because we've got Steve here, Lewis, who's sitting in the same place you're sitting on, and he's got to make a decision. So you'll hear what he has to say. Okay. Decide who you like. Which doctor do you like best that you've seen so far?
Well, I'd have to say Kishan.
Okay, so go with Kishan. There you go.
Okay.
That can't serve you badly, right? Stuart and Boykin and the other moderators?
Can I make a general comment real quick? Something that helped me a lot deciding. Over a year ago, when I first came to this group, I met another guy in the group. We were both at the same level, the information gathering and decision level. And he and I got together after the meeting on the phone, and we teamed up. And every week since then, we still do this. We talk on the phone or text or email once a week to compare notes. And I told him what my doctors said to me. He told me what his doctors said to him. We compared notes and we worked through this whole thing together and essentially supplied each other with information. We both separately talked to Chang and then compared notes. What did he tell you? What did he tell you? And that was so helpful. There are so many people tonight in this group who are at the same level, that same point. If you just reach out to one of your peers and say, hey, let's team up, let's go through this in a tandem manner, somebody who's exactly at the same spot you are, I think you'd find that tremendously helpful.
Thank you.
That's a great point, Dave. And if you want to put that information in the chat, we'll make sure before the video is posted that none of your personal information is going out over the internet. So if you want to swap information with each other, that's a good way to connect.
In the chat?
In the chat.
Okay.
You can contact me if you want. I've kind of gone down the same path. So.
Oh, great. Thank you.
Very similar pathology.
Oh, great.
So if Albert or Steve, if y'all throw your information in there, then while this is going on, y'all can collect. And
yeah, I'm not very tech savvy. I just hit send a message and add my email address.
It's the two cloud buttons. You see the people.
The
Steve's already sent his. So you see the people icon, then you see like the two squares that look like cloud tags, like quote boxes to the right of the people.
I've opened the chat.
Open the chat, then just type it in there, and then Steve will see it. We'll all see it.
Just send in the message. Okay, great.
Yep, that's all you got to do.
This teaming up, continue it through the treatment and afterward, because you're going to find that's incredibly helpful too.
Yeah. Okay, great.
Mm-hmm. Okay.
And the very, very last thing, do y'all think it's bad to do spacers, Spacor, or aerogel?
We're not going to talk about it with you.
Okay.
Because you're not there.
Okay.
What's the point if you do brachytherapy? Huh?
I still do.
And we've talked, and you've asked us that question so many times before, Albert.
Not about Barrigel or Spacor.
Yes, you have. You've asked us about Spacor, but come on back and decide if when you want to do SBRT, we'll talk to you about Spacor. You've also got to find a doctor who's going to do it. And if we say it's a great idea and Keishan says, I don't do it, then you're going to come back to us and say, oh, well, now I've got to find somebody to do. No, trust your doctor.
Okay.
Keishan.
Right. Okay, Bill. Still there, Bill?
Bill in Virginia or Bill Franklin?
No, Bill in Virginia.
I don't need any time, Boykin. Thank you.
Okay, thanks. Okay. Greg Burns.
No, I kind of gave my I really just wanted to share with you guys because I just thought my experience with MRI-Linac could be relevant. So I just wanted to just wanted to share. So if anybody has any other questions about it, I'm happy to answer them. But if you guys need the time for other people, I think there's other people in the queue.
Yes. Hey, Greg, I'm sorry. I just want to say thank you. It went over well. It helped a lot of people. I saw lots of smiles out there on the page, so it was good. Thank you.
You're very welcome. Yeah, and I like Stanford. I mean, I know there's UCLA and UCSF, but I like the facility at Stanford, and so far the team has been pretty good. So, but I'm not plugging, and I'm not getting any of the money back that they charge Medicare for it. So, anyway, all the best, you guys. Thanks.
Thank you, Greg. Okay. Sandra and Amir, we're up to you.
Hello.
Hi, Sandra.
Hi.
What's your question update? Yes.
Just a quick thing. We're continuing on our journey too, like so many other people have said. I just had a question to see if anyone knows a lot about the difference between Decipher and Artera. The reason I ask is because Amir's had both with his with the using the 4+3 and the other inputs that go into them, and the results were very different in the both the risk of 10-year distant metastasis and the prostate cancer specific mortality. And I'm just curious, which one would be more reliable, or is it somewhere in between the two?
Okay, does anybody want to take a stab at that one?
Yeah. Hi, Sandra.
Hi.
Need to understand the difference between what those two tests are. Decipher is a DNA test, and Artera is, if I remember correctly, is an AI-based evaluation test. So they're two way different methodologies.
Yeah.
And I think, you're not going to, I don't think you're going to find any definitive studies that are going to say that one's better than the other. I think you sort of need to consider what what the doctors think about when they look at these tests. Because I've had this conversation with my doctor, and they look at as additional information in terms of indications. Just tell me, since they were saying different stuff, which said which?
Yeah, his Decipher score was a 0.76. So on the 10-year metastasis, it said 10.4%, and the Artera said 4%.
Okay.
And then on the prostate cancer specific mortality, they have different time frame endpoints, but so Decipher has 15-year risk is 14%, and Artera had the 10-year risk 1.9%. And then on the Artera, they have the short-term ADT biomarker, and they give you a positive whether it would help you or not. And his was negative, so they're saying no, but yet he's got a 0.76, Decipher score.
Yeah. I'm not sure that you can fully compare the two.
Yeah.
What I know is that from the doctors I've talked to who believe and use the information, to accept the information from Decipher, they would all say that that 0.76 is relatively bad news.
Right.
That's a very high end of the scale, and they would look at that in terms of indicating this is more, if we were looking in terms of what, how serious they need to attract it, that would prompt them to be more aggressive as opposed to less aggressive. And that comes in terms of when it's a decision about do you use ADT or not use ADT, things like this. That's a deciding factor. The Artera, while I believe the conceptually what the test is trying to do, I think it's less proven because the fact it is a newer technology and it is based on matching and sampling.
Right.
So, I would take each at face value for what it says as a guide, but I wouldn't overanalyze it and worry about what they say. Me personally, because part of my decision was driven by Decipher and was high enough that I took it seriously.
Thank you.
And I would ask the doctors that you're talking to. I got a 0.76 Decipher. What difference does that make?
Yeah, we've heard from them. We have different doctors, kind of saying different things about the ADT, and then we do have in a month from now we have the cardio-oncologist, Dr. Mosley, at UCSF appointment to kind of help weigh in on the ADT since he just had the heart bypass surgery too. You know, we're trying to look at that whole big picture of his risk, but we also, it's like, you know, kind of what's the overall survival, you know, risk and benefit of adding ADT for him. So we're hoping that he will be able to weigh in on this as well, as someone is an expert in both areas, especially the cardiology area.
Yeah, and that's the question I make sure that he answers is when you start talking generally about AT, you know, make sure that, hey, my Decipher is 0.76. How does that sway your opinion?
Yeah. Thank you for that.
Okay.
Anybody else think? Okay. Steve in Malaysia. Oh, Rick, you were going to say something?
So, a couple updates. I had a bit of a snafu. I'm in the process of trying to get a Decipher score, and I'm a little different in that I actually hand my own samples and hand them over to UCLA, and they kind of dropped the ball on getting it to Verisat, so I had to shake the tree a little bit, and finally it's now at Verisat, so I probably add another 3 or 4 weeks of delay. I probably should have pushed on it sooner, but I thought they had it done. But anyway, probably 2.5 weeks out from getting a Decipher score. Rick, you know, we had been emailing. I did send that link to Chang about the results about HDR versus SBRT. I also sent you that email about what he had said prior, and he didn't respond yet to that that link. I also asked him more details around exactly what HDR treatment he was going to give in terms of the dosimetry or the dosage. So I don't know. I mean, I have a kind of a handler there, the international patients person. I think I'll kind of ping her to see if she can go, you know, whisper in his ear to get things going. But it's a little concerning that he doesn't answer things that are kind of important. After, you know, telling me what you saw the message that you have a 2% chance of recurrence, which doesn't align even close with that report. So I'm a little bit, you know, I'm tired of analyzing things. And of course, when I get this Decipher back, I want to make decisions fairly quick because I'm just about not that far off 6 months into this process. So that's, I guess, you know, so the question is, any thoughts on how to move it forward short of what I just suggested? I still got the cost issues, but, you know, I have a bit of a plan for that.
So I think we should share, and I don't know if I can remember it properly without having it open in front of me, but I think we should share that research that got published in JAMA Network last week, which I sent you when I was on the road. And it compares brachy and SBRT, correct?
Yeah.
And it comes out with, this is where you're going to have to help me, or I'm going to have to find it and put it up me. The brachy was far inferior. Was it 38% non-recurrence with brachy and something like 80%? No, what 60% non-recurrence with HDR? Is that right?
It was like about 10% versus 38.
Of recurrent.
SBRT versus 10% chance of recurrence. SBRT versus HDR.
Right, 10% chance of recurrence with the SBRT and 40% chance of recurrence with the HDR. Is that right?
Yeah, 38.
38%. Look, we even made Mr. Burns put his camera on. And by the way, guys, a forthcoming attraction, Greg and I are going to be having a little chat on the 25th of March. Mark it in your calendar on Solo Arts Heal. We're going to be talking to each other about Mr. Burns's life. And I'm really looking forward to it.
You're trying
It'll
to
be a bit late, but it'll be worth staying up for, and it will be recorded. Okay, let's get back to Mr. Lewis. You know, when there's that much of a gap, it does speak to me. And I don't know how true those numbers are. And it may be that Albert doesn't have a response to those numbers, which is why you're not hearing from him, and he doesn't want to say, well, those numbers are probably true. That could be a reason why you're not hearing from him, because those are big numbers.
I had seen that one before. I think it was probably the last version, like this is the 9-year follow-up, and that was why I didn't specifically reference that when I was talking to him, but I kind of pushed him on, you know, exactly what the numbers are, right? And he gave me the 2%, right? He didn't show me the results, you know, like as in a trial, he just said that. So, you know, I'm taking him at his word. I kind of buy the line of because I mean, I've got the same cribiform 3+4, you know, with some other bad features, but I don't have spread. But you know, if HDR is that risky, I wouldn't do it. I sort of bought the line that given that your higher dosage and it's directly on the tumors, it should be better because it's more focal, because I have a large tumor on one side. So I bought that story, and of course I didn't have to take ADT, supposedly, because he characterized me as favorable intermediate. But, you know, I think some of my features kind of kick it a little bit, you know, more into the higher risk. But so I'm kind of getting tired of thinking about it. I need to make a decision in not too long.
Yes.
Decipher score kind of.
I would say that's a good observation, Mr. L. I think you're right. Now, that said, for me, but I'm not you, it would be a no-brainer to kind of hang out until I turn 65 and then avoid the cost.
Yeah,
and
I love that. Hence, that Decipher score being low would be good.
So what was your Decipher?
I don't know. That's what I just said.
You got to get it. You got to get it. So we'll get it. But that's what I would do. And you know, even at that 3+4, even with the crib reform, you can if you can deal with it, you can probably hang out until when's your birthday? September or August? September?
December 6th.
December 6th.
Yeah.
Can you change that?
I have to go in those government databases and hack it, I guess. But
wow. There you go. All right, you know. But I think I know what I would do, which is the MRI-Linac. The dollars and cents are a whole different issue, but I think probably at this point I would do the MRI-Linac. Albert.
It's just the ADT thing is, you know, it's not all that. Right. I don't look forward to ADT. I know what you guys said earlier, so I sort of convinced myself it was fine before, because I really was on the SBRT path. But like you're saying, I think I'll wait to Decipher. If it's low, then wait until But therein is another quandary in that I've got two different opinions from two different doctors, which is, you know, what was brought up earlier. So Chang says, yeah, wait until, you don't need ADT, you can wait. Of course, Keyshawn says, no, you need ADT and don't wait. Meaning if I wanted to wait, you better be on ADT. So.
Well, it sort of means that, but maybe it doesn't. And, you know, there's
exactly.
There's a lot in there.
Right. Throw a dart and see where it lands.
Well, look, guys, you know, I do want to say that you all are, at least at this point, you're all standing in the batter's box with a fairly favorable position. If you guys were stage 3, if you guys were had extra prostatic extension, or you had something, seminal vesicle invasion, you'd have the pressure on you. But you're all in relatively good. You're all in relatively good position. So, you know, that said, you're pretty. I don't know. I mean, I think that you can decide to do what you want to do and be comfortable. And if you don't want to do the HT, it's probably not going to be, and wait, it's probably not going to be a huge difference. If you want to be safe, do the Orgovyx. You know, if you want something immediate, you can do the brachy, and
yeah,
but there is a risk of recurrence.
Yeah,
I don't think it's quite as high as what they say. I mean, I don't know. It sounds awful high that there's a 40% failure rate with HDR brachy. It sounds higher than we've seen.
I've also seen that I saw another study that was comparing four course treatment versus 2, 38 gray versus 27, and the recurrence level was a lot lower. It was closer to the SBRT number. So I haven't asked, that's one of the reasons I asked him about the actual treatment, but I think he was thinking about, you know, the 2 times 13.
Yeah, you know, maybe you need 2 shots.
Yeah.
I mean, in the old days, that's how they did it. That's how Albert did it. They give you a shot, and they'd leave the conduits in overnight, and then you couldn't move that much overnight, and then they'd take you down the next morning and give you another dose.
Well,
and you come out. It was overnight. But you know, back in the day, in 2008, 2009, 2010.
Well,
and then they started doing it with 2 shots with a week apart, which I never really understood. Who the hell wants to have those rods stuck in where they stuck them in once before? I mean, I don't get that one, but.
Well, he said to me that the treatment is, you know, 2x over 1 day. So it is one, you know, I think if it depends whether you're international a little bit too, what's your schedule. So if you're international, they'll do it all in 1 day. And, you know, so the 38 gray was a different story because then they have to do 2 implants, and they do 2 times 2. At least that's my understanding. He never proposed that. When I saw that BCR, I thought, well, okay, well, you could still do that. So anyway, so that's where I'm at. I'm still kind of on the fence on the Decipher, so I'll let that sort of drive me a little bit. And if it's high, then yeah, get my ass in gear and get something done, and maybe take ADT if I have to. So that's it. I'll pass the mic.
Well, hey, Steve, thanks. It actually sounds like you have a plan. You may not like it, but you actually have a plan.
Yeah. Well, I've gone down the earlier guy talking about focal and all that. I went through that same shit, and the whole recurrence issue, and that scared me. And I just said, forget focal. I do not want to be staring down the barrel of this thing 3 years from now and having to do it again. So that's just my opinion.
If there's nobody else that has anything, I'm going to thank you all for attending our video chat tonight. This has been a great session, and I will end the recording now.
Thanks again, Rick. I want to